The next bill we have this evening is Leader McCaffrey's bill, Senate Bill 2896, relative to food and drugs. This bill would allow distribution and utilization of narcotic testing products to assist persons in determining whether drugs contain toxic substances. We have several witnesses signed up to testify. I don't see some of our regulars here. Mike DeLauro, Steve Brown, Michael Gallup. Feel free to come forward. Lisa Peterson, Sarah Martineau, Nick Horton, and Anna Jane Yolkin. All those people, just to note, are in favor of the bill. So, Mr. Gallup, good evening and welcome.
Good evening. Testifying the bill, and it also speaks very strongly of the bipartisan support and a lot of the feedback that we've received from folks about this bill. So just to give you folks a little bit of background on where this started, I was approached by the Students for Sensible Drug Policy after I had conducted some research. That research was at the direction of the Governor's Task Force for Overdose Prevention, and there was a concern that there was no present voice from the active use community. So that research product led me to two different sets of information. One, that there's a thing called the Users Union, and that I happen to have about over a decade of experience in harm reduction with the president of the regional union. The second piece was that there's such a thing as a fentanyl test strip, and that they cost about $1. They're manufactured and made available in bulk, and that they have the highest specificity, the highest accuracy, and they're very easy to use, very easy to read, and being able to determine the presence of fentanyl in any substance, whether it's a composite, a compound, anything that can be diluted in water can be tested with the simplicity that would be equivalent to that of our home pregnancy test. So that information is extremely valuable because of several studies that were done here in the state of Rhode Island. The first by Tracy Green, looking at the feasibility of the intervention. The second of which, and more importantly, was the actual distribution of fentanyl test strips. So the importance of this, number one, is that this practice was cleared by an ethics review board, our institution's highest authority on the ethical practice of an intervention with regard to human participation, that this was considered to have no harmful impact whatsoever on the participants in the study. Secondly, that the outcome of this study, the findings were absolutely astounding, that 87% of folks who participated in the study, all of whom were opioid dependent, actually showed up for their follow-up visit. 87% is a figure we have never seen in our existing behavioral health system. Secondly was the behavior mitigation effects that resulted from receiving a positive result from a fentanyl test strip test. And so what they found was that 2 out of 3 participants actually used less drugs as a result of receiving a positive result from one of these tests. 59% of the people in the study actually went and got a second person to use with, so they would have somebody to call 911 or to administer naloxone in the event of an overdose. And 2 out of 3 of the participants also reported using their drugs more slowly. All of these behavior mitigation outcomes are led directly to a decrease in the death from overdose as a result. So there is a very, very clear line that's drawn here with the impact to reduce the death from overdose in our community at a very small price tag. Furthermore, I want to talk about some of the importance of looking at the research that's available to us about recovery. And so I want to point out the really critical research of William White. He's a very important researcher who works for NADAC. He specializes in recovery supports. He also works for Chestnut Health Systems. And so all of his research is available publicly for free online. You can go to williamwhitepapers.com and learn anything you want to learn about recovery for yourself if you want to learn about how we're going to deal with this crisis. And so in talking about that, one of the papers that he wrote, and I provided to the legislator with my testimony, is about behavioral health recovery management, which is a shift in our treatment paradigm from the crisis intervention model that we're currently using. And so in doing this, we have to look at what the field of addiction treatment has long characterized addiction as a chronic progressive disease. But the treatment methods more closely resemble those of emergency medicine than the chronic disease specialists. The addiction treatment field truly believed and acted as if addiction constituted a chronic disorder, and its practitioners would not cultivate the expectation among clients and family members that full and enduring symptom remission should be achieved from a single episode of treatment, which is an extreme fallacy that exists within our current treatment modality. View prior treatment failure as an indicator of poor prognosis. Relegate post-treatment aftercare services to an afterthought, and treat individuals in isolation from their family and social networks that provide the most sustainable support for the management of chronic health problems. It's really confusing to me why a substance use disorder that's been marked by high severity and chronicity is that during serial self-contained episodes of screening, assessment, admission, brief treatment, followed by discharge, and even briefer aftercare, we've determined is ineffective and results in shaming and punishing clients for failing to respond to an intervention design that is inherently flawed. More specifically, the argument articulates that alcohol and other drug dependencies resemble chronic disorders such as type 2 diabetes mellitus, hypertension, and asthma in their etiological complexity, that is the interaction of genetic, biological, psychological, and physical, social, environmental conditions, and of course, the relevant clinical outcomes. So in looking at our slogan, "The treatment works," to single episodes of addiction treatment makes no more sense than applying such a slogan to the acute stabilization of a diabetic coma or a hypertensive crisis. The larger question that we have to answer for ourselves is, how do we respond to episodes of treatment and recurrence in embracing folks where they're at within our existing system? And so part of what behavioral health recovery management looks to do is to establish a new fundamental principle for recovery support services that's evidence-based. And the evidence base for this recovery health management has a statement of principles that starts with the recovery focus, then we include client empowerment, the destigmatization of our experiences, evidence-based interventions, service integration, recovery partnership, ecology of recovery, monitoring and support emphasis, and continual evaluation. There are significant inherent flaws within our existing system, and so this shift in our treatment capacity will allow our providers to form a coalition, create new additional access points, to create a wider net of engagement, to allow primary care physicians to initiate conversations about recovery from a perspective that embraces where a client is at within their current what do they call that? Not the road to recovery. They're talking about there's stages as if it's a developmental process. So they're equating the recovery process in science to developmental science. So we talk about, like early childhood development. And so there's a similar model for recovery. And it starts long before the first remission, and it goes long beyond recurrence. So recurrence is when people go back out and use. So in order for us to accept and embrace that this is the true model of chronic disease that we're using to treat this, what we've developed through our experience of decades of research and working with clients and patients that works, we have to be able to embrace people genuinely where they are at. So what we did is we took that understanding, we looked at existing models for marketplace interaction, and we tried to marry the two concepts with the best of the sciences that we have available by providing testing to people, by empowering them. And then we took it a step further, and I actually negotiated with the manufacturer to have unique product codes printed onto the package labels. And then I coordinated an effort with Dr. Brandon Marshall and Max Krieger from our Department of Public Health that actually will put that information onto our Prevent Overdose RI website through mobile-friendly, easy-to-access data collection that's done in the community, so we can start to track our market composition of toxic substances as they emerge in the different communities by region, and we'll be able to issue consumer product safety alerts based on the availability of these tools. The response that we got from the Students for Sensible Drug Policy, and also in a recent application by RICARES to the Department of Health for a grant to fund the distribution of these products, was that there was a lack of legal clarity. There was also a significant concern for the potential liability because the emerging testing products had not been vetted to the extent, meaning longitudinal case studies.
Yes, so I'm sure that's all in the material that you gave us. And
Some of it, yes.
Yeah, so I guess my question is, so these products are to help people to make sure that they're not taking something that may give them an overdose. Am I summarizing it correctly? And then if that's the case, how do we deal with the people that are on the streets that may not have the doctor that you talked about? Maybe they're lucky enough to go to a health center, and I go to the prison on the second and fourth Sunday. How does this tie in with the reducing the recidivism? Because a lot of the guys that I've been going out there about 16 years, medium one, and sadly, a lot of the guys that get out, they get right back out on the street and back into their addiction, and then they end up right back into medium one. So bring it home for me, because you gave a lot of information. Bring it home for me.
Okay, so it's difficult, and I have to say that dealing with criminalization is an entirely separate matter in this particular case, that I don't think that testing availability may have a direct impact on recidivism, because there's inherent flaws within the existing criminalization system. And we've talked about that at great length, and I don't want to make that the focus of our conversation. But what I can say is that folks who die from an overdose have zero chance of recovery. And so everything that we can do to try to keep people alive.
That's the point I'm trying to get at.
Yeah.
These products are to reduce the overdoses.
To reduce the death from overdose.
Thank you.
And is it fair to say that based upon the wording of the statute that any person can provide these testing strips? So you don't necessarily have to get them from a doctor. They can be given to community centers. They can be given to treatment providers, sober coaches, that type of thing. So any person can provide.
Yeah, the current network of support not only includes community health centers, but faith-based organizations, recovery housing, street outreach teams, folks that are working directly with the homeless. I've communicated with numerous points of access. I've talked with EMS about giving these to paramedics to give them additional tools to talk with people. There's been a lot of experience of frustration by first responders for folks that are having serial overdose episodes. And then so they don't really feel like they have the tools or the education to be equipped to talk with those individuals and try to initiate change efforts. So this is a way of changing like the fundamental set of dialogue that we use to try to initiate change efforts and embrace people where they're at. By being able to show people that we genuinely care about their well-being, we're better able to instill principles of recovery into the community that we're trying to create change within.
Thank you. Are there any other questions or comments for Mr. Gallup? Thank you. Ma'am, good evening and welcome.
Hi, thank you, Madam Chairwoman and members of the committee. Thanks for the opportunity to speak in support of this bill that would provide protections around the use and distribution of testing products. My name's Anna Jane, and I'm the director of a nonprofit called Protect Families First, which promotes drug policies and practices that promote community health and safety and keep families intact. As you know, and as we've discussed earlier today, we are in the midst of an overdose epidemic. Too many Rhode Islanders are dying, and a lot of that is driven by fentanyl, a really powerful opioid that's basically ever present in the drug supply here in Rhode Island. And to give you some context, in 2017, about 2/3 of people who died from an overdose had fentanyl in their system. Fentanyl is being found not only in opioids, but also in cocaine and methamphetamine in the state. And in black market, people don't know what they're buying, people don't know what they're using, they don't know how strong it is, and people continue to use drugs despite that. So fentanyl testing strips are a cheap, fast, and effective way for people to know a little bit more about the illicit substances they're putting in their body. People can, then they may still choose to use those drugs, right? And they can make slightly more informed decisions. Perhaps they can carry naloxone, they can use with a friend, they can use less of a drug. And so it's a really straightforward, really no harm way to provide more information so people can make decisions that promote their health and safety. It could also have the benefit of allowing people who don't use drugs, people like law enforcement, family members, people who work in recovery houses, to know if there's fentanyl on site and make decisions based on that. And I know my organization does a lot of naloxone trainings, overdose reversal trainings. We'd love to include fentanyl testing strips with those if that is indicated. However, because it is in a gray area of the law right now, we don't feel comfortable doing that. But if it were fully sanctioned by the law, we'd love to do that as a public health mechanism. And as Michael talked about, research by Rhode Island's own Dr. Tracy Green has looked at this topic, and I think that she can be a really important resource as we evaluate this if and when it's implemented here in Rhode Island. As we've talked about before, again, public health tools do keep people alive, and that's a really important intervention during this overdose epidemic. I think given some of the conversations we've had earlier today, I think putting more protections in place so people do know what they're using so they can make informed decision, or do know what they're selling so they can make more informed decisions, is really important. I really hope that we can go forward with this legislation. One other thing is Mr. Delorio had to leave, but asked me to share that he has some information he'll give with written materials in support of the bill as well. Thank you.
Mr. DeLauro always gives us his written materials, so we're not worried about that. Are there any questions or comments for this witness? Thank you. With that, Senator Metz moves passage of Senate Bill 2896, seconded by Senator Lombardi. All those in favor signify by saying aye. Aye. Opposed? The bill passes.